Okay, today we'll discuss about management of status epilepticus. Next slide. We'll briefly tell about the introduction, definitions, classifications of status epilepticus, etiopathogenesis, goal of treatment, approach to the treatment, and recent studies which have been done on status epilepticus. We'll go through one by one. We'll do brief introduction. Status epilepticus is a medical emergency. If you don't treat early, it will lead to high morbidity. It will lead to high morbidity and mortality. Incidence would be around 1.3 to 74 cases per lakh population. Approximately in 50% of patients, they will not be having any previous history of epilepsy. It is U-shaped distribution that is most commonly seen in pediatric and elderly. In lifetime, up to 10% of adults with epilepsy and 20% of children will have chances of status epilepticus in the future. As all of you know, initial definition, early in 1993, it was defined as duration of seizures of more than 30 minutes, either with continuous seizure activity or 2 or more sequential seizures without any full recovery in between the episode. It was the earliest definition. Nowadays, the operational definition of status epilepticus has come. It contains two parameters, the T1 and T2. T1 means the failure of mechanism of seizure, the failure of body mechanism to stop seizure. It is different for different kind of seizures. So, for example, in generalized tonic-clonic seizure, duration would be considered as 5 minutes, and T2 is how aggressively we should treat. If you don't treat earlier, it will lead to the complications like cerebral injury. It will be different for different kind of epilepsy. So, for example, in generalized tonic-clonic epilepsy, it would be 60 minutes. In condition, the status epilepticus is a condition resulting either from the failure of mechanism that is responsible for seizure termination, or from the initiation of mechanism which leads to abnormality. That is, abnormally it will lead to prolonged seizure. That is called time point 1, that is T1, which can have long-term consequences. That is including the neuronal death, neuronal injuries, alteration of the neuronal networks, depending on the type and duration of the seizures. The time domain may vary according to the types of epilepsy. Okay. This is the flow chart. Operational definition, that is T1 for tonic-clonic epilepsies, it is 5 minutes. At focal epilepsy, it is for 10 minutes. And absence status epilepticus, that is 10 to 15 minutes. This is the duration. T1 is mainly dependent on the duration of the seizures, and T2 is the complication period. Like for the duration of seizure, if happens, it will lead to the complications like neuronal injury. In a generalized tonic-clonic seizure, if the duration of seizure is more than 5 minutes, and the complication that resulting, if the seizure activity prolongs more than 30 minutes, that will lead to the complications like neuronal injury. In a case of focal status epilepticus, you can define it as 10 minutes for T1 and more than 60 minutes for T2. In a case of absence status epilepticus, it is 10 to 15 minutes. For T2 definition, it is till now not known. Okay, you remember the time duration. It is different for different kind of seizures. Okay, for generalized seizure, duration is 5 minutes, and if it progress more than 30 minutes, it will lead to the damage to the neurons, and final outcome would be poor. The T1 time defined due to the, like, it is the earliest time when treatment should be considered as early as possible. Okay, if you treat early, it will results in early outcome. If you treat late, it will lead to complication. That is earliest time when status should be controlled to prevent the long-term consequences. The aim of the time to T2 is we should control the seizures to prevent the long-term consequence, and early that aim for T1 is we should treat early to abort the seizures. Okay. Clinical course of convulsive status epilepticus. As all of you know, status epilepticus can be classified as convulsive and non-convulsive. In convulsive, there are 4 stages. That is early status epilepticus, first 10 minutes. Established status epilepticus, first 10 to 30 minutes. Refractory status epilepticus, that is ongoing status epilepticus despite of first and second line treatment. Duration would be 30 to 60 minutes. Super refractory status epilepticus, that is status epilepticus even after 24. That is the mistakenly written. This is 24 hours actually. That is here it is written as 24 minutes. It is 24 hours even after treatment with anesthetic agent. Also, if a patient is having continuously seizures for a period of more than that is after the 24 hours of treatment. Also, if a patient is having status epilepticus, that is called super refractory status epilepticus. Okay. This is the same as I told earlier, that refractory status, super refractory status, and another two terminologies, just you know the name, prolonged refractory status epilepticus, that is PRSE, in which the at least 7 days of despite of appropriate treatment, if a patient is having status epilepticus, here in this setting, without using anesthetic. If you use anesthetic, even though after patient is having continuous seizure for a period of more than 7 days, that is called prolonged status refractory epilepticus. Okay. These are new terminologies, that is NARS and FIRES. NARS is new onset refractory status epilepticus, in which patient will not be having any prior history of epilepsy or any structural damage or toxic or metabolic causes. In febrile infection related epilepsy syndrome, patient will be having history of fever or infection between 2 weeks and 24 hours prior to the onset of refractory status epilepticus. FIRES will come under NARS. Okay, these are the new terminologies. You do
Hello, sir. Sir, you're not audible.
next slide. This slide is not available. Hello. Am I audible now?
Yes, sir.
Hello.
Yes, sir.
Am I audible? Just go to like previous slide. Just you open the previous slide. Previous one. Okay. Next. Okay. One more important entity is non-convulsive status epilepticus. This is very important in the medicine ICU. Most of the patient will come to emergency with loss of consciousness without any regaining consciousness even after treatment. Even after your extensive evaluation, MRI, metabolic parameters are normal, still patient is unconscious. In that setting, you need to suspect non-convulsive status epilepticus, in which patient will not be having any convulsive movement. There will be some subtle jerky eye movement or jerky limb movement that should be observed. In that setting, you have to put him on continuous EEG monitoring. Epileptic discharges more than 2.5 hertz that is observed continuously throughout the record. It is definite diagnosis of non-convulsive status epilepticus. In case of epileptic discharges less than 2.5 hertz, you can see other added clinical features like if patient is having subtle ictal phenomena like eye blinking, tonic eye movement, aversive movements, or limb flickering movement will be patient will be having, or any spatio-temporal evaluation of EEG. Say for abnormal frequency, amplitude changing, or from the one side of epileptic form discharge, it is going to the other side of involvement. That is spatio-temporal evaluation. Or even after giving anti-epileptic like benzodiazepine, the discharges will disappear. Okay, these one criteria along with less than 2.5 hertz discharges are definitely, if discharges are more than 2.5 hertz, you can directly label it as non-convulsive status epilepticus. Okay. Next slide. Here we are seeing almost here 3 hertz continuous spike and wave discharges. Okay, this is called non-convulsive status epilepticus. If the discharges more than 2.5 hertz recorded throughout the EEG with the background of history of like the patient come to the emergency or ICU with a complete loss of consciousness with subtle seizure activity. With the EEG monitoring, continuous EEG monitoring showing the more than 2.5 hertz epileptic form discharge, you can directly diagnose this as non-convulsive status epilepticus. Okay. Next slide. Next slide. This same as that I told earlier. 6.4 according to the age. Okay, let's come one by one. Okay, we'll see the type of or classification of status epilepticus is broadly classified as with motor symptoms or without motor symptom. In with motor symptoms, you can classify it as convulsive status, myoclonic status, focal motor status, or tonic status or clonic status. In case of non-motor symptom, you can classify as non-convulsive status with or without coma. This you remember these two names. Okay, don't go in detail. These are the broad classification you remember as convulsive, non-convulsive status epilepticus. Okay, next slide. Etiology most commonly classified as known causes and unknown causes. In known causes, most commonly we see in the acute setting like post-stroke, intoxication, infective causes like malaria, encephalitis, and if a patient is having any remote history trauma, encephalitis, or old history of stroke that is causing a gliosis and scar that is precipitating the seizures. In a case of progressive history of any gradual progressive increase in the frequency of seizures, so that is leading to status epilepticus, like in intracranial space lesions, progressive myoclonic epilepsies, laporal body disease, and sometimes advanced dementias like later Alzheimer's. You will get status epilepticus. Okay, and other syndromes like pediatric age group, as you've seen, West syndrome, Lennox-Gastaut syndrome, and Landau-Klempner syndrome, they will be also have status epilepticus, like signs and symptoms. And last one is unknown or cryptogenic status epilepticus. Etiology, most commonly we see most common cause would be stroke, and mortality will be more commonly seen in anoxic brain injuries. In a chronic setting, the patient will have poor drug compliance that is leading to the status epilepticus. So, initial mechanism, in the initial part of the seizure, there will be a concession phase. Duration of less than, if a seizure duration, initial seizure duration of less than 30 minutes, patient will be having compensatory mechanism like increasing the blood flow, increasing the catecholamine release, cardiac output, or cerebral metabolism that will initially compensate. As the seizure activity goes on, it will lead to the failure of cerebral autoregulation. That is more than 30 minutes. That will lead to the failure of cerebral autoregulation. That is to hypoglycemia, hypoxia, systemic hypotension, decreased cerebral flow, raised ICP, and rhabdomyolysis. That will lead to the multi-organ dysfunction. So, most effective way is to prevent the brain injuries. You treat the epilepsy or status as early as possible. So, main important, the model hypothesis of receptor trafficking. Initially, in the status epilepticus early part, these are all the GABA receptors. So, initial part of the status epilepticus, most of the GABA receptors will be present on the cell surface membrane. That time, if you give any GABA mimicking drugs, benzodiazepam, or any phenobarbital, that will act early and that will decreases the seizure, or that will prevent the status epilepticus. As the time progresses, that will lead to internalization of the GABA receptor, that will lead to the engulfment of GABA receptor by the Golgi complex, and finally the glutamate receptors will come on the surface membrane, that will lead to the NMDA AMPA receptor that will come to the surface membrane, that will lead to the hyperglutaminergic status, that will lead to status epilepticus. So whenever patient comes, you give as early as possible GABA mimic drug like benzodiazepam or phenobarbital to abort the seizure, so that you can prevent it to going for status epilepticus. Okay, always you treat as early as possible. Next. Similarly, okay, as I told earlier, initial stage of the status epilepticus, GABA receptors will be on the surface. Okay, GABA mainly, this is inhibitory action. That mainly mediates the inhibition. So if you give GABA mimetic drug, that will abort the seizure. So as the time process, this GABA receptor will come inside the cytoplasm, and the NMDA or receptor will go outside the cell membrane. That will lead to the excitotoxic neurotransmitter activation like glutaminergic. That will lead to the hyperglutaminergic status. So status epilepticus will start occurring. So the clinical relevance would be initial part of the seizure, BZDs and phenobarbital will have good role, At the later part of the status epilepticus, NMDR antagonist like ketamine will have better action. Okay. Next slide. This is the same slide as I told earlier. In the initial part of the status epilepticus, there will be compensatory phase. If you don't rest properly, that will lead to decompensation. So further, it will lead to refractory status or super refractory status epilepticus. So goals of treatment, mainly we have to terminate the seizures, we have to address the precipitating cause, and we have to manage the complication that is secondary due to seizures. And after once you come out from the status epilepticus, you can plan for prevention of seizure recurrence. So time is brain. So if you treat late, that will lead to the damage happens and secondary brain injuries, and permanently patient will be having neurodeficit. So you treat early as possible, like acute ischemic stroke when you are planning for thrombolysis, whatever you do, address the condition. Similarly, we have to address the status epilepticus also. This is a paragraph like this red line deficiting. If you treat a status epilepticus late, like if more than 1 hour, like patient comes to emergency, you make if you don't start earlier treatment, that will leads to the mortality. That will leads to the highest number of mortality if you don't treat early. So if you treat within less hours, that will leads to increase in the survival rate. Here almost 100% survival rate will be there. If you treat late, that will leads to the decrease in survival rate. Okay, you treat early. That is the concept. Time is the brain. So initial cup. So try to obtain IV line, because most of the anti-epileptic drug what we're giving through the IV. So if you don't access the IV, don't be panic. You can use IM preparation or buccal preparation or a nasal preparation also available, or rectal preparation will also be available. So we have to access the line. You're not able to get. Meanwhile, you plan for other lines. Okay. And as all of you, ABC is must. If you need, you can get CT or MRI. Basic blood investigation should be sugars, CBC, RFT, calcium, magnesium, electrolytes, and epileptic layer patient is taking, or any history of any poor drug complaint. You can, or patient overdose also. That time also you can order for anti-epileptic drugs. If your setup is if you are set up having any EEG, that then we tell the technician for continuous EEG monitoring. All electro also be possible. So continuous EEG monitoring would be much better in the management of status epilepticus, so that we can adjust the dose, and we can taper up, or we can escalate the dose of epileptic according to the informed discharges that are seen in the continuous EEG monitoring machine. If needed, you can plan for MRI, lumbar puncture, toxicology panel if the clinical setting favors. Next slide. Okay, pre-hospital treatment, patient like any periphery or PHG or patient coming to ambulance, that most of the time you will get benzodiazepine easily. So you can tell the nursing staff or any duty doctor, those who are in the periphery or in the ambulance, you can tell them to give benzodiazepine. So you can choose either what are the availability, midazolam, lorazepam, or diazepam can also be given. Midazolam 10 mg up to 10 mg IM stat you can be given. Lorazepam 4 milligram IM, if needed you can read again. And rectal diazepam also available. If in case you don't get any access to IV line, you can give rectal diazepam also 0.2 mg per.
Hello, sir. Sir, you're not audible.
Am I audible?
Yes, sir. Now it's audible.
This entire slide was not audible, or just
Sir, till
repeat
rectal
this slide? Huh?
till rectal diazepam it was audible.
Okay, so if IV access is not available, that time you can plan rectal diazepam also. Okay, other preparation is like buccal preparation also available, nasal preparations also available. Intranasal midazolam, like nasal formulations also available, that is come in a dose of 5 mg per 0.1 ml. Each spray contains 5 mg, so you can give one spray to each nostril. So one spray per each nostril, that will result in total delivery of 10 mg midazolam. Okay, or if nasal also not available, that time you can prepare nasal formulation by using the midazolam injections, by using the midazolam injection through the meter dose spray. So that meter dose spray you can prepare up to 0.1 ml. Okay, so by giving 2 to 3 puffs in each nostril, again it will lead to the total accumulative dose of 10 mg. Next slide. So medical management, immediate supportive care, that as I told earlier, ABC, then you can take detailed history from the family members. ABC you maintain, try to get IV line, or in pediatric case group most often they use intraosseous lines also, and send for routine blood investigations. If you are suspecting any toxic drugs, that time you can give for urine or blood toxicology reports also. Correction of hypoglycemia and metabolic abnormalities whenever you are treating epilepsy patient also. Okay, next slide. So come to the status epilepticus treatment algorithm. So you received the patient, you put the IV line and check the sugars. If sugars are on the lesser side, always before giving dextrose correction or sugar correction, give better thiamine. So 100 to 200 mg IV thiamine you give, then you start the sugar. Okay, then you start according to the hypoglycemic status. You can give D25 or D50 according to age group and sugar status. Okay, before that you need to give thiamine always. Okay, send in investigation. Meanwhile, if the seizure controls even after give dextrose in a hypoglycemic patient, then patient will be managed accordingly. If a seizure not controls even after giving of hypoglycemic correction, then you can choose the anti-epileptic. So first line anti-epileptic drug of choice would be your benzodiazepine, like diazepam, midazolam, or lorazepam. Midazolam can be given IM for a dose of 10 milligram in a case of more than 40 kg, 5 milligram in a case of less than 40 kg. This can be given only single dose. Lorazepam 0.1 milligram per kg, 4 mg per dose maximum, and you can repeat the dose if needed. In case of intravenous diazepam, you can give to 0.1 to 0.2 mg per kg, maximum up to 10 milligram per dose. You can repeat the dose. Okay, if these three preparation are not available, you can opt for phenobarbital or rectal diazepam or intranasal diazepam or buccal midazolam. Okay, this is the first line of treatment after doing ABC and sugar correction. If a patient having a seizure attack, then you give this BZDs. BZDs are not available, you can give phenobarbital. This is the first 5 to 20 minutes of initial therapy. Next slide. So this is the same slide. Diazepam, which enters the brain earlier, within 10 seconds it will act. So, but the duration of action would be very less. After 20 minutes, it will cease. In case of lorazepam, it will start by 2 to 3 minutes and persistent duration of action up to 12 hours. Midazolam, it will also start within few minutes and duration of action would be 1 to 1.5 hours. And dose, as I told earlier, midazolam and lorazepam would be like almost 0.1 to 0.2 mg per kg. You can repeat one dose, but not in case of midazolam. In lorazepam diazepam, you can repeat one more dose. Meanwhile, you need to look for hypotension, respiratory depression, or any sudden collapse whenever you are giving the benzodiazepam treatment. Okay. Next slide. Okay. After giving diazepam, you need to watch for the patient. Some in case of hypoglycemia or any provoked seizure, most of the time after correction of hypoglycemia, seizures will abort. That time you don't need to give other second line anti-epileptic drug. When to give second line anti-epileptic drugs? If unprovoked seizures are there, patient throwing seizures continuously, consciousness not at regain, that time you need to plan for second line of anti-epileptic drug other than benzodiazepine. Okay, next slide. Okay, you can choose
Sir, not audible, sir.
Now?
Yes, sir.
Okay.
Sir, this entire slide has to be.
Okay. So if your center, like whatever the drugs which are available in the hospital, you can use. So most commonly, what we use is phenytoin, fosphenytoin, valproic acid, levetiracetam, or phenobarbital. Fosphenytoin and phenytoin, same dose, that is 20 milligram per kg, but duration or rate of infusion is different. For fosphenytoin, you can give up 150 milligram per minute, but in phenytoin, I think 15 to 30 milligram you can give. Valproic acid, levetiracetam, you can give, like for valproic acid, as they told, like up to 40 milligram per kg you can give. Maximum dose would be 300 milligram. For levetiracetam, maximum dose would be 4000. Textbook says up to 16 milligram per kg can be given. If these are not available, you can give phenobarbital also 15 milligram per kg. In the second line of therapy at the duration of 20 to 40 minutes. Okay. After that, you assess the patient you wait at least for 10 minutes. Okay. To the drug action to come, you need to wait for at least 10 minutes. If seizures abort, patient gain the consciousness, then you can plan for according to the patient status, you can treat. Okay. If seizures again, patient is having continuously throwing the seizures, even after second line of treatment, that time you need to decide whether to give anesthetic agent, or we can again we can give the previously loaded drugs or other anti-epileptic drugs. That depends on clinical scenario or personal experiences. There is no clear evidence that what should be given next if the second line fails. Okay, you can give either loading dose of previously mentioned drugs, or you can go for anesthetic. Okay. Next slide. This is like doses of the second line anti-epileptic drug. As I told, phenytoin up to 20 mg per kg. Fosphenytoin also same dose. Valproate 20 to 40. Levetiracetam 40 to 60. Phenobarbital 10 to 15. Lacosamide, this is newly recently approved in the treatment of status epilepticus. That is 200 to 400 mg IV. Meanwhile, you need to see per ECG. Sometimes it may lead to PR prolongation or heart block. Recently, it is added drug in the management of status epilepticus. So you need to see for the administration rate. Phenytoin, 50 mg per minute. Fosphenytoin you can give early, like 150 milligram per minute. For valproate and levetiracetam, around 5 mg per kg per minute. Phenobarbital 50 mg per minute. Lacosamide, that is 200 mg over 50 minutes. So almost all anti-epileptic, most of the time it will causes arrhythmias and hypotension. You need to see in the monitors while whenever you're giving the anti-epileptic drug. Okay. Doses of the first three can be repeated after the loading infusion. So you give the loading dose, wait for 10 minutes, and if you want to give another loading dose, you need to wait at least for 10 minutes. Okay. Next slide. This is a recent one. This is a recently approved drug is lacosamide. Okay. Some of the studies, that is rampant study, it's showing that midazolam is better than IV lorazepam. The main would be for midazolam, most of you can give without IV access, and time to action, like per IV access, it will take another 5 to 10 minutes, like taking the patient inside, cannula and connecting, that will take time. But IM, it will act early and given directly without using the cannula. So these studies shows the primary efficacy point is better IM midazolam compared to IV lorazepam. And veteran affairs status epilepticus study, in this lorazepam in the initial part of status epilepticus would be better than phenytoin. And third one was ESSET trial. It was showing there is no significant difference, efficacy difference between levetiracetam and fosphenytoin valproate group in a patient with status epilepticus. So you can use either of these drugs according to your hospital facility. And Eclipse trial, it is showing also there is no significant superiority of levetiracetam over the phenytoin in the efficacy. Okay, but the side effect profile says the better drug would be levetiracetam as compared to phenytoin. And fosphenytoin is better tolerated compared to phenytoin. If your center having the fosphenytoin, use better fosphenytoin rather than phenytoin. Okay. Next slide. So after giving loading dose of anti-epileptic, if patient is having continuously throwing the seizures, you can take an option. One, you can repeat the same drug which I have given earlier, but don't give full dose. Say for example, you have given phenytoin 20 mg per kg already. If you want to reload it, don't give again full dose. That will lead to toxicity. Okay, that will lead to toxicity, acute cerebral ataxia, arrhythmias. Okay, better you give half dose or 5 mg per kg. In a case of phosphonate, 7.5 mg per kg. Okay, or you can select the drug which are not taken in the which are not given in the first 20 minutes. Say for example, if I given phenytoin, that time you can choose valproate or levetiracetam for reloading. If you want to give same drug, that time you need to reduce the dose to at least half, or phenytoin for 5 mg per kg or phosphonate 7.5 milligram per kg. So even after that, if these are not controlled, you can label it as refractory status epilepticus. You need to manage refractory status epilepticus accordingly by using the anesthetic. Okay. Any doubt in this slide till now? You can ask.
No, sir.
Okay, go ahead. Next slide. So this is a flow chart. You receive the patient, ABC, basic routine blood test, sugars. If hypoglycemia is there, treat hypoglycemia along with thiamine supplementation. Meanwhile, you give benzodiazepam according to the availability, lorazepam or midazolam or diazepam. After that, you need to load the drug. You need to load with second line anti-epileptic drugs like phenytoin, phosphonate, valproic acid, phenobarbital, or levetiracetam. Even after that patient is throwing the seizures, you can choose either of these drugs, or you can go ahead with the injectable injectable anesthetic agent in the form of midazolam or propofol or ketamine. Okay, even after that also patient continuously throwing seizures, you can go last with the pentobarbital. Okay, next slide. Next slide.
Sir, third line.
Okay, now it has come. Okay, am I audible?
Yes, sir.
Okay. Well, so whenever.
Hello, sir. Not audible, sir. Hello, sir.
Hello.
Yes, sir. Now you're audible, sir.
Audible. Okay. So midazolam and propofol commonly available in our government hospital. So for midazolam, you load with the dose of 0.2 mg per kg. Then you can start the maintenance dose from 0.05 mg to 0.5 mg per kg per hour. Meanwhile, you need to connect the patient to continuous EEG monitoring. So according to the epileptic form discharges, you can plan for escalation of dose or maintenance of same dose. Okay. So you start with 0.05 to 0.5 mg per kg per hour. So meanwhile, you need to see for respiratory depression and hypotension. And second drug would be propofol. Again, you can load with 2 mg per kg. Then you can give maintenance dose of 2 to 10 milligram per kg per hour. Then other drugs are pentobarbital, thiopental, and ketamine. Almost most of the drugs having loading dose of 2 to 5 mg per kg and maintenance dose of 2 to 5 mg. So just remember grossly 2 to 5 mg per kg per hour. Okay. Meanwhile, you need to see for the complications of drugs. Okay. Next slide. Okay, duration. How like most of the data that are available in status epilepticus management would be better use easy that burst suppression. That burst suppression means the epileptic palm discharges completely come less than 50% of the amplitude. So that is called burst suppression. Till that time, at least you need to continue the anti-epileptic infusion. And you need to see for both clinically and electroclinically. So if a patient having complete seizure free and easy showing also normal alpha, beta, theta waves without any epileptic form discharges and complete burst suppression of epileptic form activity, that time you can start tapering the anti-epileptic. It is recommended that at least 24 to 48 hours of electrographic control before slowly withdrawing the anesthetic drug. Okay. Sometimes the triphasic waves are often recorded during the anesthetic tapering. Not every sharply counter EEG transition should be cause for concern. So don't don't think that patient still in encephalopathy. Sometimes drugs also causes triphasic waves. Okay. Don't see only isolated epileptic form discharges. You need to see complete uh, like status epilepticum continuous 2 to 2.5 hertz frequency continuous epileptic form discharges that are significant, not only considered as only isolated single lead epileptic focal epileptic form discharges, not a contraindication for tapering the anti-epileptic drugs. Okay, the duration of treatment is also inadequately studied. In general infusion, we typically continue for 24 hours of clinical and electrographic seizure suppression, and then gradually tapered over 12 to 24 hours. Minimum you wait for 24 hours. You see for clinical and electrographic findings. If completely patient clinically improved and EEG showing normal record without any epileptic form discharges, okay, you can gradually taper after that. Okay. Anyway, pentobarbital having very long half life, you can no need to gradually, you can rapidly you can stop the pentobarbital as compared to other drugs. After that, stopping of the that is injectable anesthetic agent, you need to overlap with the drugs that you are giving. Okay, don't stop longer acting anti-epileptic drugs like me. Whenever you loaded with the levetiracetam or phenytoin, that drugs that also be continued. Don't stop those drugs. Okay, because if you stop anti-epileptic drugs that are given during the admission time, that will lead to reoccurrence of seizure, and again there will be higher chances of status epilepticus. Okay, you should give proper therapeutic level of longer acting anti-seizure medication before tapering the anti-epileptic anesthetic anti-epileptic drugs. Okay, poor prognosis. If a patient come to the emergency more like after occurrence of after 5 hours of status epilepticus, if a clinical seizures of duration more than 3.5 hours, if patient is having structural brain damage like in case of stroke, anoxia, or infection in an elderly age with associated multiple comorbid medical conditions, if patient is having a focal neurological deficit, will have poor prognosis and poor outcome in a status epilepticus cases. Okay. So some of the scores are used to assess the prognosis of status epilepticus. That is EMSC score, that is epidemiology-based mortality score in status epilepticus, and STES score, that is status epilepticus severity score. Depending on the clinical features, you can give the point. So next slide. If a EMSC score of more than 79 and STES score of more than 4, will have higher rate of status epilepticus related mortality. Just you can calculate based on the patient condition, and you can explain the prognosis to the patient attenders. So this is the brief algorithm, as I told earlier: pre-hospital management, initial management, definite management, that is second line and third line anti-epileptic drugs. And if in case of super refractory drugs, super refractory cases, you can continue the higher anesthetic agent. In a case of super refractory status epilepticus, fires, NARS, even after giving this anesthetic agent, if a seizure is not controlled, other proven beneficial therapy would be steroids, IV immunoglobulin, magnesium sulfate, pyridoxine. All those things can be tried. In a case of a failed failed seizure activity, even after giving the maximum dose of anesthetic agent, you can opt for immunomodulating therapy. Okay. Next slide. Okay, these are all the reference. If you have any doubt, kindly ask me. Okay.
Sir, benzodiazepine should be given as fast as possible, no, sir?
Yes, yes, yes.
Then why are we giving midazolam as a third line infusion, sir?
Midazolam, that is in status epilepticus. If you, that is initially whatever you that to abort the initial attacks.
Yes, sir. Then
Initial there will be GABA.
if GABA receptors are internalized, sir, then will midazolam act if we are giving in third line?
Third line, yeah, third line, like after giving the second line anti-epileptic drug, like that time NMDA receptor will be on the surface. You are telling, no?
Sir. But GABA will be internalized, no, sir. So what is the rationale of giving it as a third line drug, sir, midazolam infusion?
Yes, this I didn't thought of. Okay, I will read and let you know. Okay,
Okay, sir.
good question.
That's all, sir. Sir, we'll end the session.
Any other? Okay, okay.
Yes, sir. Thank you, sir.
Thank you.
Well,